I'd like to thank Dr. Cody and the other organizers for the opportunity to present on this very important question. Can radiotherapy replace axillary lymph node dissection after positive sentinel lymph node biopsy? I'd like to begin by talking about the motivation for us to seek an alternative to axillary lymph node dissection. Because although axillary lymph node dissection has been used for quite some time with both therapeutic intent and the intent to gain information necessary to guide adjuvant therapy decisions, it has significant consequences for our survivors. Patients struggle with the quality of life effects of lymphedema, which can at times be quite severe. And that has motivated us to seek alternatives. I'd like to thank Dr. Gurdeep Manu for assembling this wonderful slide that summarizes the extensive research that has been done over the years trying to optimize axillary management. I'll touch briefly upon one of the older comparisons of axillary management, the NSABP B04 trial, just to provide some historical context before spending most of my time in this talk focused on the sentinel lymph node biopsy era, and specifically two trials that have addressed exactly the question that I was asked to cover in this review. Historical studies were very important in laying the foundation necessary to de-escalate axillary surgery. The NSABP B04 is one of the most famous of our historical axillary management trials, and it was, as most of you know, a randomized trial that took clinically node-negative patients and randomized them to radical mastectomy versus total mastectomy with regional nodal irradiation versus total mastectomy, and it took clinically node-positive patients and randomized them to radical mastectomy versus total mastectomy with regional nodal irradiation. And it found similar regional recurrence rates, regardless of whether patients received radical mastectomy or total mastectomy with regional nodal irradiation, with a recurrence rate in the regional nodes after 25 years of follow-up of only 4% with either radical mastectomy or total mastectomy and regional nodal irradiation. Moreover, lymphedema was less common in the patients who received regional nodal irradiation. Arm edema was recorded at least once in 58.1% of the patients in the radical mastectomy arm versus 38.2% of those in the regional nodal irradiation arm. Finally, the substantial incidence of pathologically positive nodes in patients with clinically negative axilla meant that axillary lymph node dissection would be used to guide adjuvant systemic therapy decisions for many years after this trial was conducted, until the advent of the sentinel lymph node biopsy. And so now I'd like to take the remainder of my time and discuss two trials that specifically addressed the question that I am to cover here, the Amorous trial and the otosaur trial, and I will cover these sequentially. First, the Amorous trial was led by the EORTC, and it included 1,425 patients with clinically negative axilla and positive sentinel lymph node biopsy. And these patients were randomized before their axillary surgery, before their sentinel lymph node biopsy, to either axillary lymph node dissection, which included dissection of at least levels 1 and 2 and at least 10 nodes, or axillary radiotherapy, which included 25 fractions of 2 gray, treating all 3 levels of the axilla and the medial supraclavicular fossa. And you can see the trial design depicted there very nicely in the right lower corner. And I want to thank Dr. Rutgers for many of the images that I will share with you. And you can see here the numbers of patients and how they ended up with 744 sentinel lymph node positive patients included in the intention to treat analyses who received axillary lymph node dissection, and 681 who were assigned to axillary radiotherapy. Now let's pause briefly and just remind ourselves of the patient characteristics, because it's important anytime we're applying a clinical trial to make sure we generalize to patients who are similar to those that were enrolled on that trial. So on Amorous, 40% of the patients were premenopausal, 82% received breast conserving surgery, 95% had only 1 or 2 positive sentinel lymph nodes, and this is very important. The vast majority had only 1 or 2 positive sentinel lymph nodes. 60% had macrometastases, 61% received chemotherapy, 78% received endocrine therapy. This was not in the neoadjuvant setting, it's important to note. And in the axillary lymph node dissection group, 220, or 1/3 of the 672 patients, had additional positive lymph nodes. The primary objective of Amorous was to show the non-inferiority of axillary radiotherapy compared with axillary lymph node dissection with respect to 5-year axillary recurrence in patients with a positive sentinel node. And a 5-year axillary recurrence rate of 2% was assumed in the axillary lymph node dissection group, and non-inferiority was defined as an axillary recurrence rate not higher than 4% in the axillary radiotherapy group. 52 events were needed to ensure a power of 80% under those assumptions. However, very low event rates were observed. And so ultimately, the Independent Data Monitoring Committee approved proceeding with analysis, leaving the primary non-inferiority test underpowered. And what was found was that outcomes in terms of disease control were equivalent, with axillary recurrence occurring in 4 out of 744 patients in the axillary lymph node dissection group and 7 out of 681 in the axillary radiotherapy group at a median follow-up of 6.1 years. So the control appeared to be comparable, but again, the caveat being that this was underpowered due to the low event rates. Nevertheless, no striking differences in axillary recurrence, in disease-free survival, in overall survival, as you see there in the table, but a dramatic and striking difference in lymphedema. And so let's look at that in more detail, shall we? So you can see here on the left that the lymphedema rates were, you can see over here that on the left, sorry, I'm having my left-right confusion of a radiation oncologist today. On the left, you can see of the screen that the control rates were very similar. But you can see on the right in the table on lymphedema that at 5 years, 23% of the patients who had axillary lymph node dissection had clinical signs of lymphedema, as opposed to 11% with axillary radiotherapy. And also in the text, you can see that there were no differences found in range of motion between the two treatment groups when they looked at all 4 excursions. And there were no statistically significant or clinically relevant differences in quality of life between the groups for any of the selected scales, arm symptoms, pain, or body image. Post-hoc analysis of the swelling and shoulder movement items suggested that fewer patients in the axillary radiotherapy group reported a swollen hand or arm, and fewer patients in the axillary lymph node dissection group reported difficulties moving the arm. And we'll have more on that in just a second because they gave us a 10-year update at San Antonio a couple of years ago. After 10 years, axillary recurrence had developed in only 1.82% of those assigned to axillary radiotherapy versus 0.93% of those assigned to axillary lymph node dissection. Neither distant metastasis-free survival nor overall survival were significantly different between the two treatment arms. The cumulative incidence estimates for 10-year local regional recurrence were 3.6% for axillary lymph node dissection, 4.1% for axillary radiotherapy. No significant difference there. Interestingly, more second primaries were observed after axillary radiotherapy as compared to axillary lymph node dissection, although many of these were in the contralateral breast. Now here, they did a deeper dive into lymphedema and shoulder mobility. These are still only out to 5 years, but with more complete data and more detailed analysis. And you can see here, again, vividly depicted that 5-year difference in lymphedema, with the axillary lymph node dissection group in blue having considerably more lymphedema than the other group, the axillary radiotherapy group, in red. And here you can see the more detailed information on shoulder function, and it's very important that there was no significant difference in all 4 excursions, and that trend towards impaired movement after axillary radiotherapy was really in the first year only. So that's very, very important information, and we eagerly anticipate the publication of this important update of the trial. I'd like to move on to the otosaur trial, which has published 8-year results, very similar design, in which eligible patients were those with clinically negative axilla and tumors that were clinically up to 3 centimeters in size, and they were randomized before surgery to axillary lymph node dissection versus 50 gray of regional nodal irradiation. Again, the targets were all 3 levels of the axilla, the supraclavicular fossa, the dose and fractionation, 25 fractions of 2 gray each. And you can see here that there were no differences in the disease-free survival or overall survival, although the post-progression survival after recurrence was actually higher in the patients who received regional nodal radiation, but no worrisome signal that replacing axillary lymph node dissection with regional nodal irradiation was causing a decrement in disease control. And similar to Amorous, the rates of lymphedema, paresthesia, swelling, arm pain, shoulder mobility issues were higher in the axillary lymph node dissection group at 15.3% than in the radiotherapy group at 4.7% at 1 year. And interestingly and importantly, combining axillary lymph node dissection and radiotherapy for those with 4 or more positive lymph nodes in the ALND arm increased morbidity. 31.5% of those had clinical signs of these challenges. Importantly, though, there was no statistically significant and clinically relevant difference in quality of life noted between the two groups. So in summary, Amorous and otosaur tell us that axillary radiotherapy is absolutely a reasonable alternative to axillary lymph node dissection for patients similar to those enrolled on these trials after a positive sentinel lymph node biopsy. Keep in mind, these were patients who had clinically node negative axilla and mostly 1 to 2 positive sentinel nodes on their biopsies. So there are still some lingering questions. First, do all patients like this need directed axillary radiotherapy to all 3 levels and the medial supraclavicular field as administered on these trials? So I want to just briefly touch upon a couple of trials on that point, the International Breast Cancer Study Group 2301 and the ACOSOG Z11 trial. And then I will touch on very, very briefly whether some patients might benefit from adding on internal mammary nodal fields as well, by briefly mentioning the NCIC MA20 and EORTC 22922 studies, which we'll be able to return to in the question and answer if people are inclined to hear more. So the International Breast Cancer Study Group 2301 trial was a trial of patients with micrometastases. Remember that 60% of the patients on the Amorous, 60% of the patients who got regional nodal radiation on the otosaur trial had macrometastases. So this was a lower risk population. But in this trial, patients were assigned to completion axillary dissection or not. And the ones who didn't get completion axillary dissection, many of them did receive whole breast irradiation, but a fair proportion actually received partial breast irradiation, which would have been unlikely to give any dose to levels 1 and 2 of the axilla. And many of the 10% or so of the 900 or so women on this trial who received a mastectomy as their surgery didn't receive any radiotherapy at all. And so what this study suggests is that at least for some patients with micrometastases, it may not be necessary to radiate all of the areas that were radiated in Amorous and in otosaur. And Z11 is another study of about 900 patients, again, looking at completion axillary lymph node dissection after a positive sentinel node or no further axillary surgery, but what was intended to be whole breast irradiation and adjuvant systemic therapy. And just like on the International Breast Cancer Study Group study, very low rates of axillary recurrence, no difference afforded by completing the axillary lymph node dissection in this patient population. But some questions about what radiation fields are appropriate, because even though no third field nodal irradiation was to have been administered on Z11, unfortunately, because more specific dose and field definition guidelines were not described, it turned out on a quark analysis of the actual radiotherapy fields administered that a substantial minority of the patients did receive directed nodal irradiation. And you can see there, a whole spectrum of types of treatments that these patients received, starting with standard tangents in panel A, higher tangents in panel B, and then really what looks like the Amorous and otosaur type of third field directed regional radiotherapy in panels C and D. And so given that NCIC MA20 and EORTC 22922 also showed benefits from comprehensive regional nodal irradiation, including a directed third field to the supraclavicular fossa and coverage of the internal mammary nodal region in patients with primarily N1 disease, this complicates the decision about the optimal radiotherapy field design here, but that's actually not the question I was asked to cover today. I just couldn't resist mentioning this because I'd love to get to this in the discussion if we can. The question I was asked was, can radiotherapy replace axillary lymph node dissection after a positive sentinel lymph node biopsy? And I would say that for patients like those enrolled on Amorous and otosaur with clinically negative axilla and 1 to 2 positive sentinel nodes, the answer is definitively, overwhelmingly, compellingly yes. However, there is a caveat. And as the authors of the Amorous trial themselves wrote, the Amorous trial cannot answer the remaining question of which subset of clinically node-negative sentinel node positive patients still require axillary treatments. In our opinion, if further axillary treatment is needed in clinically node-negative sentinel node positive patients, axillary radiotherapy could be chosen instead of axillary lymph node dissection because it provides comparable axillary control and less morbidity. So it's very important. If you're going to do more axillary treatment, axillary radiotherapy seems reasonable, but it doesn't necessarily mean that all patients require further axillary treatment. And in fact, that IBSCG 2301 and Z11 trials that I've just shown you suggest that there are some patients who do quite well without any directed axillary treatment. So in conclusion, we can integrate the findings of these landmark trials to conclude that in patients with clinically negative axilla and 1 to 2 positive sentinel nodes involved, axillary lymph node dissection can safely be avoided. There are trials ongoing to look at questions that are not answered by those trials. For example, what to do in the setting of neoadjuvant therapy. And I think we'll have a chance in the question and answer to answer that question and also to discuss the thornier issue of what we do when the patient has 3 or more positive sentinel lymph nodes, which really isn't the representative or typical patient on those trials. What exactly we do for radiation therapy is also a thorny and complex question and depends again on an assessment of clinical risk. In some patients who are at higher risk, comprehensive regional nodal irradiation, including all 3 axillary levels, the medial supraclavicular field, plus internal mammary nodal radiotherapy is warranted. In others, tangential field designs that deliver some dose to axillary levels 1 and 2 may suffice, maybe high tangents and actually making sure that we get adequate dose to levels 1 and 2 may suffice. And some with the most favorable risk features, and I'm thinking here about ER positive micrometastasis, may not even need any further therapy directed towards the axilla. As always, care in this circumstance must be individualized, but fortunately, many patients can safely forego axillary lymph node dissection in the modern era, even when they're found to have a positive sentinel lymph node biopsy. I want to thank Dr. Rutgers again for many of the pictures that I've shown in this talk, and this very last one that again takes us back to why we pursue this in the first place. It is for our patients. It is for their quality of life as survivors. We are so fortunate to treat a disease that leaves so many long-term survivors, and so we can focus on ensuring that they do well and they feel well for those long lives that they have to pursue. Thank you so much, and I look forward to the question and answer and discussion.